next one, the last speaker today, I think is one of the best unique speaker, my colleague, Dr. Amr Farghaly. Dr. Amr is a senior registrar at James University Hospital, Ireland. Also is ACLS and Pulse and ATLS instructor. Also Dr. Amr simulation instructor, Asset Center, Ireland, and European Diploma in Intensive Care certified, Focus Ultrasound Intensive Care also certified, Fellowship College of Anesthesiologists Ireland, and Membership College Anesthesiologist certified. So, mashallah, a lot of certificates. Welcome, Dr. Amr. All of us waiting your next presentation. Dr. Amr will talk about the perioperative management of patient with renal failure. So please, Dr. Amr, go on. All of us waiting you. Thank you. Dr. Amr, can you go?
Hi, everyone. Thank you so much, Dr. Hamdi. Can you see my slides?
Yes, go on, please.
That's great. Thank you so much for Dr. Saad Mahdi for inviting me to be with you today. It is a great pleasure, and it is really very, very nice and valuable course. I would like to thank Prof. Lansari and Prof. Hala for very nice lecture. It's very hard to keep the standard, but I will do my best, no pressure. Thank you so much for all attendees for your time. I'm really sorry I can't keep eye contact with you, but I will do my best to keep my presentation kind of engaging to all of you at that time. You are full of knowledge now. It will be kind of quick review for what you have watched in the last two presentations. So I will start with the case presentation. We have a male patient who is 65-year-old, had background of hypertension, diabetes. His creatinine is 130, that's milliliter per liter. I know in Egypt it is milligram per deciliter, but here it is in Europe, it is millimole per liter. Urea is 20. And this patient presented with acute lower limb ischemia for angioplasty and proceed. So that's a very common case scenario for an anesthetist working in vascular surgery. And tonight I am speaking kidney. So I'm looking for the creatinine, which is 130, urea, which is 20. So it is very clear that this patient had a deranged kidney function. So it could be either acute kidney impairment, AKI. It could be this patient has chronic kidney disease, CKD, or it could be both of them, AKI on top of CKD, or this patient could have already established end-stage renal disease on dialysis. So that will be the outlines of my presentation tonight. I will start with the AKI. So it is very clear that AKI is acute kidney injury. So it should be acute. And we will speak a little bit more about the time frame. And then it has a sustained release, a decrease in the renal function, which is very variable. Sometimes it could be mild reversible. Sometimes it could be permanent, and this patient will need RRT, which is renal replacement therapy. So the definition of the AKI, the acuity of AKI had a different classification. The first classification came with rifle. That's the old classification. So as you can see, it is really very busy table with different stages. And the second one was Aiken system classification. And then the last one is KDIGO, which is Kidney Disease Improving Global Outcome Society, came up with staging for the AKI. So for the sake of the simplicity tonight, I will try to make everything simple and clear. I have the three classification in one table for my colleagues who are going for exam in order to make it simple for them to try to remember these classifications. They are very, very important and one of the well-known questions in the different exams. So the definition of the rifle will be increased in the serum creatinine more than 50% of the baseline in less than 7 days. So it is acute within a week. The Aiken is increased in the serum creatinine, again, the same, more than 50% or more than 0.3 milligram per deciliter in less than 48 hours. And then KDIGO is using the same values in the creatinine, which is more than 0.3 milligram per deciliter in less than 48 hours, or more than 50% in less than a week. So the definition depends on the serum creatinine and also the urine output. As you know, urine output for normal adult patient is 0.5 to 1 mL per kilo. So it should be less than the normal, which is less than 0.5 mL per kilo per hour for more than 6 hours. So that's the general definition of what each one of those state classification. So now we'll go for the classification in details. So stage 1 KDIGO or stage 1 AKI, which is equal to risk. So it will be increase in the serum creatinine 50% in rifle, or in the AKI more than 0.3 or more than 50% within the same duration. So this stage almost the same like the definition. And in KDIGO, again, the same, it is increasing the serum creatinine more than 0.3 or more than 50%, and the duration is 6 hours. So stage 1 KDIGO, AKI, or risk is exactly the same as the definition. Now, if the kidney function didn't improve and the patient is deteriorating, we'll go to the injury. So it is more severe. So the increase in the creatinine will be double, more than 100% in rifle, and in AKI and in KDIGO. And the urine output will be much less for prolonged duration. So more than 12 hours, less than 0.5 ml per kilo per hour. And if the kidney function is getting worse, again, we'll go to the stage of failure. And here will be the serum creatinine more than 200% in the 3 classification, but the urine output will be for more than 12 hours, less than 0.3 mL per kilo per hour, or totally anuria for more than 12 hours. And then rifle has another two more stages, which is only specific for rifle. We have the L, which is loss. So the kidney function will be lost for a month, which is 4 weeks. So this patient will be dependent on dialysis. And this can help the discussion with the family, because everyone will be asking for how long will be on renal replacement therapy. Is it going to be just a transient or permanent dialysis? And then in this stage, which is more than 3 months. So if the patient is dependent on dialysis for more than 3 months, there is no chances this kidney will be recovered. That's according to the classification. So as you can see, this classification is dependent on the serum creatinine, which is really a very sensitive marker of the renal function. But, you know, a small rise in the serum creatinine reflect a big increase in the deterioration in the GFR. You can see in this curve, the GFR is in the horizontal curve, and the plasma creatinine is in the vertical. So the serum creatinine will start to increase after the GFR is more than 50% of the normal nephrons had been already lost. So a small rise in the serum creatinine signifies a huge damage in the kidney function. So what about the AKI? Is it very common preoperatively? So the incidence of the AKI, unfortunately, it is very, very high. It represents 20 to 25% of AKI related, which happen in hospital, all the hospital-acquired AKI. So it's a huge burden on the healthcare system. We are, as anesthetists, are part of this problem. We are involved in this problem, and we need to intervene appropriately in the right time. The incidence in general for every surgery is very wide range, between 1 to 25%. And of course, it depends on the surgery and the patient and the classification of the AKI. And if this happens, there is a huge, massive risk and huge increase in the mortality up to 60%. And that's very clear because the patient will be admitted to the ICU, will have prolonged admission in ICU, prolonged hospital admission, the patient exposed to risk of infection, and then the recovery is really very low, and the patient can progress to chronic renal failure and could be dialysis dependent, which is end-stage renal disease. Unfortunately, the chances for recovery of AKI, perioperative AKI, is less than 15%. So it is really very, very serious condition, and I have no words to attract your attention to treat those patients very, very quickly and very, very appropriately. What is the etiology of the AKI? That's already covered by Prof. Hala, but very quickly, I just have the well-known causes, which is pre-renal, renal, and post-renal. It has no other causes. Everything will be fed in this 3 classification. As we know, pre-renal, so it is either the preload, the problem is in preload, so the patient could have some sort of bleeding, dehydration, extravasation, or the problem is the blood pressure itself, which is commonly happening due to sepsis, low cardiac output, or heart. As you know, interaction between heart, liver, kidney is very, very important, or local renal circulation, and that's caused by physician as well. So the drugs we are giving to our patient, ACE, ARBs, non-steroidal, or if the patient has a specific renal vascular disease, chronic kidney disease, chronic liver disease, or don't forget that the kidney is an organ in the abdomen. So if the abdominal pressure increase, it can cause local hypoperfusion to the kidney. Then intrinsic causes, which either direct tubular injury to the kidney, or metabolic syndromes, or autoimmune. So direct tubular kidney injury to the kidney could be due to sepsis, systematic inflammatory response, which could be due to sepsis, the surgery itself, if the patient going for cardiac surgery, cardiopulmonary bypass, or if the patient exposed to hypotensive, and that's our rule as anesthetists looking after the patient, is not to allowing a continuous drop or even for short time drop in the blood pressure. And then if the patient have nephrotoxins, which is well known as part of the antibiotics that as aminoglycoside, and also the contrast, which you can't really avoid in specific certain procedures. And then pigments, which is rhabdomyolysis, and then if the patient having hemolysis during the cardiopulmonary bypass. Then metabolic syndromes, which is increasing the calcium or increasing the uric acid, and autoinflammatory, which is usually caused by glomerulonephritis, vasculitis, thrombotic microangiopathies, and interstitial nephritis. And then post-renal is very easy. Either a problem in the prostate, or the problem there is a stone elsewhere in the kidney or ureter, or there is a problem in the pelvis, retroperitoneal fibrosis, pelvic mass, or the problem is in the bladder. So that's the etiology. So it is a huge problem with different multiple risk factors. So we need to be able to pick up which patient is at huge risk in order to look after this patient very, very closely and very carefully. So the risk factor, it is very, very important. My advice to my colleagues going to any exam, classify or die. So it is patient factor, operative factor, surgery factor, and drugs. The patient factor is the age, and as you know, when you have an exam, the age group, it changes according to the age of the examiner. And then male patient, unfortunately, males are exposed more to this risk. If the patient have chronic kidney disease, chronic cardiac failure, hypertension, liver failure, diabetes, sepsis, limited cardiorespiratory reserve. And then surgery, on the top of the list is emergency surgery, cardiac surgery, vascular surgery, liver transplant, intraperitoneal surgery like laparoscopic surgery. This patient can come also for intraperitoneal, laparoscopic intraperitoneal insertion of the peritoneal dialysis catheter. Duration of the surgery itself, if there is hemorrhage, if there is massive blood transfusion, and if the patient during the surgery exposed to hypovolemia and hypotension. Then drugs, it is well known, non-steroidal anti-inflammatories, the ACE, the ARBs, some of the antibiotics as aminoglycosides, immunosuppressives, starch. I don't think any anesthetist is giving starch anymore, and then the contrast. So now we identify the risk factors. So why the cardiac surgery is coming on the top of the list? So the cardiac patient coming for cardiac surgery has a risk of AKI, which is 1.1% increase in the risk of the AKI in general. And then the mortality will increase for those patients when they have AKI and cardiac surgery to 63.7, which is huge risk and massive increase. And then the AKI itself, acute renal failure itself, increased the mortality by 7.9-fold in added risk to the risk of the surgery. And the same risk of the mortality had been found also in vascular patients. So we need to understand, and I think this is also very quite clear to everyone, but just a quick summary. Those patients exposed to vascular and cardiac surgery will have a renal hypoperfusion. And we know our physiology as anesthetists, this is part of our daily practice. We can't forget our applied physiology. So the kidney had a self-auto-regulatory reserve. So the kidney perfusion pressure can be between 50 to 150 of mean map pressure will be still maintained, but outside this limit, there is no way to maintain the renal perfusion pressure. SIRS, which is part of the surgery, especially major surgery like cardiac surgery and vascular surgery, is another risk factor. Which is specific for the vascular surgery. When they do embolization, there is a risk of renal emboli. So it could be the tissue or the lipids or air or part of the thrombus could go to the renal vasculature and cause obstruction. And of course, the duration of the surgery, or if there is risk of hemolysis during the surgery, it can cause direct tubular injury. And also patient will have a contrast during vascular surgery or some of the cardiac surgery. So if the patient came, for example, with MI, had PCI, had contrast, and now this patient come for emergent cardiac surgery, valve replacement or cabbage surgery. So there is a double risk of the contrast, risk of the cardiac surgery, and the risk of the emergency. Endovascular surgery, of course, it is mini surgery in comparison to the open surgery, but still the patient will have a contrast, and the contrast is very bad to the kidney, as all of us know. That's a very nice article if someone wants to explore more about the AKI and how to manage it. So we really, as anesthetists, facing those patients every day and every night, we need to have a kind of practical approach, how we deal with this patient pre-operative and intraoperative. As Prof. Hala said, we need to optimize the volume status of the patient, the cardiac output, which is the stroke volume times the heart rate, and the systemic blood pressure. We need to make sure that we stop any nephrotoxic drug. We need to make sure that the blood sugar is maintained within normal acceptable range all the time. We need to make sure that the electrolytes are normal, the pH is normal. And if the surgery is elective and we can postpone it until the kidney will recover, will be good and better for the patient and for the surgeon, for the anesthetist, for everyone. And also, we try to have dialysis for those patients pre-operative if there is time to optimize them before the surgery. So I said optimization of the preload. It has been well studied that we need to have a goal-directed therapy of the IV fluids. We can't really give IV fluids without any guide anymore. So we need to titrate the fluids and inotropic fluids, drugs according to cardiac output. So different manometers can be used as esophageal Doppler, pulse contour wave like BICO or Vigilio, whatever available in different hospitals, and also people using markers of end organ hypoperfusion as serum, as arterial lactate. So when we use a goal-directed therapy, we improve the prognosis of the AKI. Not only that, we decrease the amount of the fluid is given to the patient. And as you know, in the old days, it was well known that more fluids, more recovery of the kidney, and people don't really care at that time about the positive balance. But recently, it is very clear that positive balance is associated with increased mortality in ICU and poor outcome, prolonged mechanical ventilation days. What type of fluid is already discussed by Prof. Hala. So it is balanced solution. Saline is associated with hypercholelemia, which is bad to the kidney, can cause restriction of the renal vasculature and increase the risk of the AKI. Albumin already had been used, and it has been shown that it could be used for those specific group of patients having AKI, and we need to limit the volume of the fluid we are giving to those patients. What about the vasopressors? So as we know that we need from our physiology, the kidney received around 20% of the cardiac output, which seems to be a lot of the cardiac output, but actually, in fact, the kidney extracts only very little oxygen. So the renal AV oxygen difference is only 1.5 ml per deciliter, which is really very little. And to attract more your attention, I have this table for you here. So you can see the cortex will receive 94% of the renal blood flow, but the medulla will receive only 60%, which is quite tiny, small amount. The blood flow in the cortex is 5 milliliter per minute, and the medulla is 0.03, which is again very, very low. The BO2 in the cortex is 50, while it is in the medulla is 8, and the oxygen extraction ratio is 0.18 in the cortex and 0.79 in the medulla. So it is very, very important to understand as anesthetist that very minimal reduction in the total cortical or medullary blood flow can result in a very severe hypoxia in the medulla and very severe ischemic injury to the medulla. So we need to maintain the mean arterial blood pressure, which is essential for the renal perfusion, which is essential for the renal function, which is essential for the transglomerular filtration. And the systemic vasoconstrictors will increase the renal blood flow rather than increasing the resistance in the renal circulation. And now people had in the literature, when you go to review literature to find what is the magic number of MAP we can follow, it is a bit of debate, but most people agreed that MAP of 75 is good enough to increase the oxygen delivery and good enough to increase the GFR, and above that could be compromising to the renal perfusion pressure. In the old days, people used to have dopamine, and actually all the new trials had showed that dopamine is ineffective to reverse or the AKI. So as we know that dopamine agonist drugs, when it is used preoperatively, it may or may not increase the iron output, but in the same time, it doesn't affect the prognosis of acute renal failure. It doesn't reduce the mortality. It doesn't reduce the need for the dialysis. The other drug is phenol-dopam. There are still good evidence in the literature that it increases the renal blood flow. It is dopaminergic 1 receptor agonist. And in the meta-analysis of huge number of patients, 1,290 patients included, as it has been shown there is beneficial effects, especially in critically ill patients. I remember in the old days, I have used N-acetylcysteine for all patients going to have a contrast with AKI, but all the new evidence in the literature that the NAC N-acetylcysteine is not protective or preventive of the prognosis of AKI. What about other medication? What about diuretics? Diuretics could be used in AKI, but their use should be limited just to control the fluid balance, as positive balance is bad, and ideally we need our patient to be eubalanced all the time and to prevent fluid overload. But it doesn't really alter the prognosis of the AKI, or it doesn't improve the GFR. But there is a big meta-analysis that have been done, and it has been shown in 555 patients there is no adverse effects of diuretics. So the current practice, we use it, and we use it at a stress dose, which is 1 milligram per kilo. Some patients may respond, some patients may not respond, but still we can use it, especially if we think about fluid overload and pulmonary edema. What about the cardiac surgery? As an anesthetist, we're having a patient with AKI coming for cardiac surgery. What can we do to minimize the risks and to prevent the deterioration of the AKI? So as we know, we need to optimize the volume status, the systemic arterial blood pressure, avoid nephrotoxic medication, maintain a very tight blood sugar. That's the only condition we need to maintain tight hypoglycemia. As you know, NICE trials have been shown that there is no difference between tight or normal blood sugar control for surgical or medical patient, but that's a specific case situation here. We can think about off-pump bypass, because to decrease the incidence exposure of our patient to systemic inflammatory response and hemolysis, we need to, if the patient has to go on bypass, we need to try to keep maintaining the perfusion pressure a little bit higher than expected. We need to have an expert surgeon which can finish the surgery very soon, very quickly, as much as he can. We need to avoid giving our patient too much fluid, avoid hemodilution. We need to avoid red cell transfusion. So usually we use cell saver, which is kind of the same bypass machine. They give us a plus at the end of the ultrafiltration, and we advise them to do ultrafiltration also. If the patient has to take blood, we prefer it is leukocyte depleted blood to be given, and consider hemofiltration during the cardiopulmonary bypass. What about the other big risk surgery, which is a vascular surgery? How can we decrease the risk of AKI, minimize it, and prevent the prognosis, the progression to chronic renal failure? So first of all, we consider endovascular procedure, which is much better, much less risk than open procedures. Avoid using any nephrotoxic medication, again, which is the same. And as the same regarding the glycemic control here, try to be tight glycemic control. And if usually the vascular patient will come to us with acute cardiac dysfunction, so we try to treat them as soon as possible. We try to control any source of bleeding. And as we know here, bleeding or much fluid in the abdomen can, if the patient having aortic aneurysm, can cause an abdominal compartmental syndrome, which again is another risk factor. This patient at risk of sepsis, so try to manage sepsis very, very quickly, and try to manage any rhabdomyolysis if it happens, and it is a risk factor for that surgery itself, intra-abdominal hypertension, and then try to try to support organ dysfunction in the right time. And people are saying that there is a big debate in literature between early and late dialysis, but the recommendation if the patient is in the failure stage of rifle, they recommend to start in dialysis. It may help to that kidney to kick back in and to prevent the progression of AKI to chronic kidney disease. So regarding the contrast, we try to use a recommendation, use the lowest possible dose of hypoosmolar contrast, and try to avoid the accumulation of the contrast. So if the patient has a contrast the day before, don't break him to the surgery the next day. Try to have a gap if it is possible, if it is not emergency surgery. And try to minimize the volume of the contrast. Try to make sure the patient is well hydrated. And people are saying that you can give up to 3 mils per kilo isotonic crystalloid 1 hour before and 1 mil per kilo up to 6 to 24 hours afterwards. Again, that's only a rough guide. It should be guided by the clinical condition of our patient. So AKI is very risky and is part of our daily practice we face with every patient. So what is the clinical course of AKI? So the patient will come with acute kidney impairment and maybe having some risk factor on the baseline. Maybe the patient exposed already to nephrotoxins, or maybe there is some sort of chronic kidney disease. And then the patient will come to the surgery and will be exposed to hemodynamic instability, hypotension, hyperperfusion to the kidney. And that's the window we need as anesthetists to intervene very appropriately in the right time and very quickly to prevent this from happening. And if this happens, we already missed the boat. So the patient will have a subclinical tubular injury, which is established AKI. And then our role is kind of limited at that stage. So we will continue supportive management and try to avoid the secondary injury. And the outcome of established AKI is a recovery or non-recovery. Recovery have a chances of normal kidney function, which is less than 50%, which is tiny little, or progression to chronic kidney disease. And then non-recovery is chronic kidney disease or end-stage renal disease. So if the patient didn't improve, they will go for chronic kidney disease, and this classification is already well covered by Prof. Hala, so I won't waste my time going through the classification, but that's very important question in the exam for classification of the chronic kidney disease. Etiology as well is well covered by Prof. Hala, so I won't repeat the same causes. And as you know, the chronic renal failure will occur when the GFR is less than 10%. And when it drops less than 5%, this patient will be end-stage disease, will depend dialysis. And it is a huge problem. Again, the chronic renal failure is around 7% every year in UK. So when it is biochemically evident, the chronic renal failure, when it's less than 40% of the kidney is functioning, and dialysis when it's less than 10% of the nephrons are functioning, so this patient will require dialysis. Okay, usually once daily. So the type of dialysis, the frequency of the dialysis, and the date of the most recent dialysis. So we prefer for every elective surgery to have dialysis 12 to 24 hours prior to elective surgery to kind of optimization for our patient, optimization of the pH, optimization of the electrolytes. But we need to know some patients will miss the treatment for different reasons. So it is very important to know the date and the time, and also where is the dialysis line, where is the dialysis access. So we need to know where is it the type and where is the location to try to avoid and carefully deal with it. And I will come through this later on in my presentation. And we need to know how much fluid this patient is allowed to take and how much urine output. You may be surprised by some patients, they have 0 urine output every day. So in order to actually estimate how much amount of fluid you are going to give our patient, you need to know their daily intake and output. Also, we need to know the dry weight of our patient, and is it achieved and is it accurate? Some patients, after reaching the dry weight, they may have nausea, diarrhea, vomiting, they may lose more, or they may drink more water or gain more weight. So it is also very important to know the dry weight of our patient. We need to have a recent serum creatinine and serum urea level, and we need to know about the potassium. It's already explained very well, can't be explained any better than Prof. Hala, so I will skip this point. Also, patient during dialysis, we need to know, was it kind of a stable dialysis, or the patient have a specific intervention, a specific medication was given, and where is for me is that in chronic renal failure, the handling of the water, the handling of chronic the patient coming with fistula, we need to know if there is any increase in the size of the fistula over time. AV fistula, it could be an aneurysm, and this can precipitate cardiac failure because of increased venous return to the heart. So as you can see here in this photo, this looks like an aneurysm. It is actually an AV fistula, but with this time, this usually happen. Endocrine system is well already explained and covered by Prof. Hala. This patient will have also peripheral autonomic neuropathy, so careful positioning, handling of this patient, the neck, the shoulders, the hip, easily fracture, so it's very important, and again, is major source of complaint against the anesthetist. This patient could be immunocompromised from the drugs, from the disease, and they could have what's called Steele syndrome. So Steele syndrome, what happened is there is a diversion of the arterial blood flow through the fistula, and this will lead to limb insufficiency and limb ischemia. Also, the medications those patients are taking, it's already covered by Prof. Hala, so I'm not going through details of the medications they are taking. Okay, now I have a patient coming for AV fistula. Could it be a day case surgery? Yes. End-stage renal disease is not itself contraindication to ambulatory surgery, especially if this patient have a regional technique, and it is possible to discharge this patient who had a new fistula in the same day. Regarding the choice of anesthetics, it is a kind of common sense, as all of us know. It relies on the anesthetic experience, the experience of the surgeon, the surgery itself, and at the top of the list is our patient. It is a patient-centered care. Regarding the local anesthetics, so it could be used for patient coming for renal replacement access surgery like permicast insertion, dialysis line insertion. And also, you need to know that those patients will have usually metabolic acidosis, which will reduce the duration of the action of the local anesthetic and will reduce the protein binding, which means that the percentage of unbound drug is already increased. And those patients has already low threshold of seizures. So we have two risk factors that makes those patients at a big risk of having seizures and increased potential toxicity. That's why it is well advised that the maximum dose should be reduced by roughly around 25%, and it is always titration to effect. Esters are hydrolyzed in the plasma, so it's fine to use it. And also amides, it is metabolized by the liver, but excreted by the kidney, and there is no reports that it accumulates in the renal failure, so it is still could be used. If the patient coming for vascular access for dialysis, what is the role of regional anesthesia? We need to keep in mind certain concerns or issues. It's already highlighted by Prof. Hala, but I will just go very quickly through some of them. So the platelet dysfunction. So the platelet could be normal number, but how much of those platelets are functional normally? Also, the platelet will have altered adhesion and aggregation. Some of those patients will have a significant cardiac events and will be started on antiplatelet medication. Some of those patients will have dialysis, and there is a residual heparin effect after dialysis, which is well known. So if the patient coming to have AV fistula, usually upper limb blocks, which is axillary block, is usually used, and it helps the fistula formation. It helps to avoid the intrinsic risks of the general anesthetics, and it also causes vasodilatation, which really helps the surgeon. It makes the surgeon so happy during the surgery. And also we avoid all the interaction with the general anesthetic drugs in terms of pharmacodynamics and pharmacokinetics, which is completely changed in renal failure patient. It also helps the graft patency, so the fistula will be working fine for afterwards, and it will maturate in shorter time. Usually takes a week, but with regional anesthesia, it could be days, and the failure rate will be lower. And also it will be patent for higher rate and for longer time of period. And this patient will have an excellent analgesia, and we can discharge those patients at the same day to go home. The problem when you're doing the axillary block, you need to keep in mind that the intercostal brachial nerve, which is 2-2, is innervation outside the axilla. It is not part of the axillary block, so it needs to be blocked in the axilla separately. So that's very important. And sometimes you could be unlucky and having a patchy block, so the surgeon maybe need to top up your block. Some patient will be very anxious. You need to give kind of sedation, and you need to be very, very cautious, very careful about what you are giving the doses, and titrate to effect, and careful observation and monitoring of our patients. And also the coagulation state of our patient is also very important. General anesthetics, in generally, it is well covered by Prof. Hala. I will go just very quickly. As we know, cardiovascular complication is very common in those patients. Neuropathies and reflux, so most people prefer to have endotracheal intubation rather than having LMA. If you are going to give regional anesthesia and general anesthesia, you expose your patient to a huge risk of hemodynamic compromise. And take care, this hypotension will also compromise the fistula function. So that's really very, very harmful to our patient. IV insertion could be quite tricky and difficult. You need to know where is the sites of the future fistula, and you need to preserve it and don't try to break the site of the fistula. So in general, avoid the antecubital fossa and avoid the forearm. And if the patient coming for emergency and have difficult peripheral access, we still can use the indwelling dialysis line. But you need to know that this line is already heparinized. So make sure you aspirate first to avoid bolusing the heparin to our patient and increase the risk of bleeding. And also you need to completely strict antiseptic technique because of the risk of the infection. And after you finish, you need to hip lock against those lines, otherwise you will be blamed for the blocking those lines, which is really precious line for our patient. Monitoring, we use blood pressure cuff. You make sure that's away from the size of the fistula. If you have to use arterial line, if you have to use it, you use it, but in general, we try to avoid arterial cannulation unless it is really very, very highly indicated. The role of anesthetic agent in patient who had renal failure is already mostly covered by Prof. Hala. I'll just go through some of the things, probably all of you know it. So there is impaired excretion of all water-soluble drugs and the active metabolites. And also the half-life of this medication will be increased because it will accumulate. Keep in mind all the time, dialysis doesn't replace the normal kidney function. It's only part of the kidney will be replaced, not full function. Plasma protein is already little and it is diluted. So the drugs that need to be bind to albumin will be having increase in the free fraction, with increased risk of toxicity and side effects. There is a change in the volume of distribution for those patients. So this patient could be dehydrated, having smaller volume distribution and having increased steady state concentration. And also regarding the acidosis and decrease albumin and proteins, so the risk of increase the free portion of the drug. Induction agent already covered by Prof. Hala again. So cybontone and benzodiazepine in general doses should be reduced by roughly 30 to 50%. And again, test titrate to effect. Propofol, there is no big change in him in pharmacokinetics, but there have been some reports that those patients may need surprisingly increased doses of propofol. Muscle relaxant already well covered. We need to avoid succinylcholine if we can, especially if there's hyperkalemia. We use non-depolarizing muscle relaxant, although it is usually excreted by the kidney, but it is relatively safe to use most of them. The initial dose we are off by redistribution, which is well known, but the problem with the maintenance doses, which can reaccumulate, and that's why we need to reduce the maintenance dose for those patients. Of course, atracorium is in the top of the list because it depends on the Hoffman degradation, which relies on the patient pH and the patient temperature. Prochronium still can be saved, but keep in mind that the excretion of Sugammadex, which is a reversal use here in Europe in most centers, that it accumulates. So the Sugammadex prochronium complexes, it accumulate, and it is difficult to excrete it by the kidney. So in general advice, if the patient have a creatinine clearance less than 30, you need to reduce the dose of Sugammadex you are giving to those patients. Apart from that, we give the same dose. Also, vicronium, mevacronium can be used. A small percentage of them are excreted by the kidney. Galamine should be avoided. And other long-acting like pancuronium, alcuronium should be avoided. Curare could be used, but we need with strict caution. In generally, I think most people don't really use it. And then keep in mind there is a potentiation of paralysis for those patients. Part of it is due to the acidosis, part of it is due to the hypomagnesemia, the hypocalcemia, the hypokalemia, and also part of it is the medication we are giving to our patient like aminoglycoside. So usually it is recommended to have NMT, neuromuscular monitoring, for those patients most of the time. Opioids is already well covered by Prof. Hala, so I don't want to waste your time repeating the same information. Inhalation anesthetics could be used without problem, but keep in mind that there is a decreased elimination of the fluoride, which is the metabolites of the enflurane, sevoflurane, and bisoxyflurane. Post-operative, what we need to do for our patient. Again and again, I can't stress anymore, fluid balance is very, very crucial, very meticulous. Keep an eye on fluid balance all the time. Try to avoid risks of dehydration overload. So if the patient having vomiting or diarrhea, try to intervene appropriately and very quickly. If the patient having post-operative hemodialysis session, try to postpone it because the risk of the bleeding with the heparin given. And some patient, you expect this patient can have a big change in their mental state even with a small normal dose of opioids or analgesic given. Paracetamol, safe to use, no problem. There is no dosage change is needed, and it need to increase the interval between the doses, and that's not because it is metabolized by the kidney. It is metabolized by the liver, as all of us know. But the problem is metabolites, which is glucuronide and sulfate conjugate, can accumulate if the patient have a severe renal impairment, but there is no evidence of harm in the literature. So I'm going to end my presentation now with a home message, which I hope it will be helpful to everyone. All dialysis patients are a high-risk patient for cardiovascular complications, so don't take it lightly. This patient have a significant physiological change, so it is not a normal patient. End-stage disease is a specific category of patient, which is different from chronic renal failure and AKI. Regional anesthesia, of course, it is good in all the time if it is done in the with the safe hands, in the safe time, and with a safe way all the time. Renal replacement therapy does not mean that we can't have a daycare surgery. AKI is very, very common in the preoperative settings. It's a huge problem with major surgery. We try to associate with increased mortality, so we do our best to minimize the risk factor for our patient. And the main problem is try to avoid the ischemia, avoid the use of any toxins. And the key non-pharmacological strategies, it is a given in this presentation, it is to keep intravascular expansion volume, maintain renal blood flow, maintain renal perfusion pressure, avoid any nephrotoxic medication, and tight control of the blood sugar or careful control of the blood sugar all the time. Avoid any post-operative complication and manage it in the right time all the time. And that's it. That's my references. Thank you so much for your time. I hope you gain some knowledge from my presentation. Thank you.
Thank you, Dr. Amr. MashaAllah. Very informative, very illustrative lecture. Thank you. Well done, Dr. Amr. So, Dr. Wafaa, do you have questions?
Yes, we have 3-4 questions. The first one, if the patient hypovolemic or have hemorrhage or hypotensive, can we use a colloid in this phase just for resuscitation?
So in the literature, albumin can be used for resuscitation. Of course, it is preferred all the time to use balanced crystalloid solutions. But albumin, yes, albumin can be used to try to limit the amount of the fluid that given for resuscitation. And of course, it is very important to control the source of hypovolemia. So it is, if it is hemorrhagic shock, we need to control the source, which is the bleeding. Otherwise, whatever we are giving to the patient, we are not really going to correct the primary problem. And if we need to have to give blood transfusion, of course, we'll give blood transfusion.
Okay.
Dr. Amri, sorry, Dr. Wafa, they're asking specifically for Volvin. You know, the Volvin, and a lot of literature say about this side effect about the kidney. So
Yes.
we can use it as a colloid, or it's not advised.
I don't think it is advisable to use it. I think if we're going to use colloids in general, albumin will be the first choice. Gel of fusion. Volvin, hydroxyethyl starch had been very clear in literature it is harmful to the kidney.
Yes, totally agree. Totally agree.
Yes, the second question, what do you think the best vasopressor drug for these cases?
So in literature, noradrenaline has been, lots of reports had been shown that noradrenaline increases renal perfusion pressure and renal blood flow as well. Usually it is not noradrenaline as a standard, we use it most of the time. And then if the patient is still hypotensive and we try to work, it is a matter of balance. We need to work on the preload, the cardiac output, and then the heart itself, and then the vasopressors. So if noradrenaline is not enough, you can go for vasopressin as well, but make sure that you optimize the preload of the patient and optimize the cardiac function.
Good. One more question, Dr. Am. You know, you mentioned for the EV fistula as a daycare surgery, we can use a regional technique like supraclavicular block. So again, as you mentioned,
yeah.
So it's okay. You can hear me now.
Yeah. Go ahead, please.
As you mentioned, as a daycare surgery for the AV fistula, we can use a regional technique like supraclavicular block. So, what do you think? We can use it as a technique to in operation for the AV fistula. And the second question is, what is the dose? You mentioned we have to decrease the local anesthetic 25% from the actually dose.
Yeah. So rule number one, when you're doing block, you try to find about the most safest and less invasive block and will cover the surgical field. Okay. So supraclavicular block has a risk of pneumothorax, while the axillary block is a risk is much less. So when you go lower in the arm, you avoid contact with the pleura. And you want this patient already has a poor baseline function of his lung, of his or her lung and the kidney. So try to avoid the complication. Of course, it is supraclavicular is the upper limb, is the spinal of the upper limb, so it can cover this area, but it won't be more than benefit than the axillary block. So the standard current practice, which I have seen, and I think it is in most places they use the axillary block. The doses usually, as you know, roughly, generally speaking, the dose of our local anesthetic is 2 milligrams per kilo. I said to reduce the dose 20 to 25%. So people usually use 1 to 1.5 milligram per kilo for the maximum upper limit of dose. Actually, when you are scaled in the ultrasound, you do it under for certain time. What you actually around every nerve is 2 to 3 mils of local anesthetic, which will be more than enough.
Yes. The advantage of ultrasound technique, you can use very minimum dose.
That's right.
Thank you, my dear.
Can I ask a question to Dr. Amr to excuse the panel and do that? Yeah?
Yes,
go ahead, bro.
Yeah. Right. Mu'taz Abdurrahman, Manchester, UK. Thank you very much, Dr. Amr. It's an excellent, obviously, presentation and everything. The point I would like to talk about is intraoperative renal supportive therapy, not just in the ICU. So during the operation itself, in our place, we tend to go for hemofiltration and sometimes hemodiafiltration all through the operation. Now, it's cumbersome. You need the personnel for it. You need 2 or 3 nurses to carry on the whole thing whilst the operation is happening. I don't know what other people do. It's actually very successful for us, but it comes with a huge resource. So what do you think about that?
Yeah, of course. As you said, it is really a massive resource usage. And it is, we try to, if you have a cardiac patient, we try to have kind of hemo ultrafiltration on the cardiopulmonary bypass machine itself. I haven't came myself across a patient in theater having started hemodialysis in theater, but what we do for this patient, we try to have, if it is a non-elective surgery, we try to have a hemodialysis beforehand, or we try to do it afterwards. Of course, there is a risk of bleeding afterwards, but it's only I came across cardiac patient who have hemodialysis in theater. That's what I have seen.
That's fine. Yeah, we use it for burns actually, and we use it for major surgery in AKI and patients who are septic. But I mean, as I say, we find it very, very exhaustive in resource. So yeah, but it does work. Yeah, that's fine. Yeah. Thank you so much.
I want to ask you, Muhammad, one question.
Yes, Prof, please go on.
Thank you for this nice and excellent presentation.
Thank you.
Really, very nice and attractive. I want to ask you, you have experience with using phenoldivam in ICU? It is available in your hospital?
No, it is not available in my hospital, no.
Not using before, okay.
No.
About the questions which elicited now about hemofiltration, really it carry highly excellent results, especially in cardiac failure and septic patients, specifically if we do it pre-op. I agree. I agree for continued venous hemodialysis filtrations. Thank you for your excellent presentation, Dr. Ahmed. Really, I am enjoying it.
Thank you, Prof.
All of us enjoy.
Really, very nice.
Thank you, Dr. Ansari and Dr. Amr. Thank you.
Thank you so much. Thanks. Thanks, Prof. We learned from you, Prof. Samir.
Oh, thank you.
I conclude.
And
Yes, by
Dr. Ara, we are enjoyed today.
Thank you all. I enjoyed
Really.
all of
Your lecture highly attractive. Your generation is more better than our generation. Really.
No. I'm learning from you, Prof. Thank you so much for that. Thanks, Prof.
Thank you very much for this really very informative night and the elite webinar tonight for this modular teaching. And thank you very much for 2 excellent moderators from Makkah al-Mukarramah. When you pray for Haram, just to pray for us as well. Prof. Samir, you are the icon of this webinar, and we have the 2 guest speakers today, Professor Dr. Hala Izzat, and my excellent colleague, very good achiever, Dr. Amr Farghaly. I'm so proud that I'm working with him in Ireland. And all panelists and all attendees, thank you very much for your patience during this time. I think we are approaching 3 hours now. Our attendees are the same since we started, even increased at the last minute. I can't thank you enough.